think we can start. And so I'll just say welcome everyone to the AO Mentor Mentee session. And this one is between me, Chip Rout, I'm here in Houston, and Dr. Marc Swiontkowski in Minneapolis. And so, Dr. Swiontkowski, thank you very much for doing this. We are all very anxious to have you participate. Your history with AO is really extensive, and you've had probably the most impressive career that anyone that I know of. And so we're anxious just to know, how did this all start for you, and what even led you into orthopedics?
This is a long story for sure. So when I went to medical school, I went with the notion that I was going to become a pediatrician. And I started with the notion that all surgeons were assholes until I found out that I was one. Basically, people who took charge, could make decisions, and actually cut another human being on way less than perfect information. I did a surgery rotation, which convinced me that I was really like these people, more like them than I wanted to admit at the time. And then I did a pediatrics rotation where at the end of 2 weeks of the well baby clinic, I wanted to jump off a bridge. So it was what confirmed my direction towards surgery. And then I did an orthopedics rotation at University of Southern California and met Dr. J. Paul Harvey, who was a legend at LA County. He and Mike Patsakis and Tillman Moore were the three attendings that ran a very busy orthopedic service. And it was at a time when internal fixation was starting. There were people in pockets around the country that were picking up more aggressive use of internal fixation. And although they didn't really have a tight link with the AO at LA County, when I asked Dr. Harvey as to where I should train, he called everybody boy. And he was my advisor, and he said, boy, I don't think you should do your residency where you do your medical school. I don't think it's good for you. So there's these two guys up there in Seattle who are doing a lot of really aggressive stuff with fractures. And I'm not sure I agree with some of it or all of it, but I think they seem to be honest people, and you should get on up there, and that's where you ought to train. Yes, sir, Dr. Harvey, that's where I'm headed. So I did a externship there. I wasn't stationed at Harborview. I was assigned to the Children's Hospital and met Carol Tights, who was the chief resident. And Carol Tights thought that I had some potential and advocated strongly for me when it came time for the match. And then I matched there. And in those days, we did a general surgery rotation, not much in orthopedics. And my very first rotation as a second year was at Harborview. In those days, we were supposed to do 6 months, but I loved it so much that I actually traded a colleague 3 months for the VA for another 3 months at Harborview. So I did 9 months at Harborview as a G2 because I loved it so much. And we were doing some really interesting stuff in those days. We only had Kuncher nails in those days, and we were bending them to put them in retrograde, and we were drilling holes to put cortical screws through them to be nails that controlled rotation, because we didn't have store-bought nails. I actually inserted the first store-bought nail with holes in it that had a guide to drill screws through it in late 1980, the Clem Shellman nail. In those days, the AO really was in favor of plating femoral shaft fractures, not putting nails in. So we used to have these debates at all the AO meetings, particularly in Europe. But anyway, that's how it started for me.
And so Dr. Harvey was your mentor in a way, and you followed his advice, but then you also enjoyed your time in Seattle.
Oh, yeah. Yeah.
And then the people in Seattle that then became your mentors, who were they?
Well, it was Ted Hansen. Bob Winquist had left Harborview and was at Swedish Medical Center later on in my training, and I didn't have much contact with him. But what I used to do is later in my residency, Bob was the only guy who had much experience with fixing acetabular fractures, like you did today. So I used to, I had him call me anytime he was going to do one. He would do them at Swedish. He would do them at Group Health. He would do them all over the place, and I would go. And most of the time, we were doing these at 6 or 7 o'clock at night, and I would assist them. And so I did have a fair contact with Bob Winquist, but it was mostly Ted Hansen, and then Al Bach was there, a wonderfully gifted hand surgeon who also could do anything in trauma, and Rob Veith was there as well, and they were great friends and mentors as well. And then a little bit later on, Bob Foster came as an educator to Harborview, and also was very important in mentoring me and how to behave and how to act, kind of thing.
How did you know to then pursue the research avenue that you chose? Or could you tell us a little bit, after your residency was over, you were drawn or led or pushed or shooted into trauma? Or how did that come about?
Yeah, well, there is a link to USC with that story as well. I've already talked about the 3 attendings that managed this incredibly busy LA County Hospital. So there was a fracture conference every Monday night in which one of the chief residents, I believe there were 10 at the time, 10 per class, they would present a series of cases. The 3 attendings would sit in the front row, and then the residents would sit behind that, and the students would sit in the back. So I was in the way back on a Monday night, and one of the chief residents presented 5 cases of femoral neck fracture. They were varied in age. I think one was 18, another one was like 20s or 30s, another one's like 40s and 50s, and then a couple older ones. And in every case that came up, they always deferred to the attendings in the front row. What should we do with this? And for all 5 cases, the answer was the muscle pedicle graft, which was an operation that most trainees today don't know anything about. It was pioneered by Jude of the imaging fame, where the patient was prone on a fracture table. You stuck 3 or 4 Hagee pins in to fix the fracture. You osteotomized the insertion of the quadratus femoris off the back of the proximal femur in a 3 by 1 centimeter musculo-osseous pedicle, rotated it 90 degrees, dug a trough in the back of the femoral head, stuck it in there, and put a screw in the back of the neck. So that, to me, was the answer for everything. So I already mentioned I did 9 months at Harborview, and very early in that time, a 62-year-old man who fell off a scaffold came in with a displaced femoral neck fracture, and I had to call Dr. Hansen, who was on, and Dr. Hansen asked, "What would you think we should do?" And I said, "Muscle pedicle graft." And he laughed out loud, and I couldn't see, but I could sense his belly was bouncing all over the place. This was the craziest thing he ever heard of. Well, he knew of the operation, but he said, "That's the stupidest thing that anybody could have ever imagined." And that was the moment I became a researcher, because how is it that it's the answer for every fracture 1,100 miles to the south and 1,100 miles to the north? It's absolutely a joke. So somebody's got to be right. And it seemed to me that somebody ought to be working on figuring out what works and what doesn't. And so that's kind of what I've been doing ever since 1980.
Could you talk about after your residency, then how did you use research as your one of your calling cards, so to speak?
I guess it's just always been worthwhile for me to do it. I can understand that it's not worthwhile for most people because of the wonderful field that we work in. I mean, it's way more fun to go to the operating room with a difficult fracture and leave satisfying you've improved that patient's horizon for a better outcome. You can do that in, I don't know, 2 to 6 hours for one of the most difficult pelvises you do. But to do a research project that's going to move the needle, sometimes that's years. Sometimes it's close to a decade. And there's not a lot of people who want to sign up for that stuff. So I think in a way, people who want to do this kind of stuff are made. They're not, I mean, they're born, they're not made. I don't think you can convince anybody, particularly in our field, that it's sane to invest that kind of effort when we can go and take care of a patient and get, near immediate rewards. But anyway, back to your question. I started with doing retrospective cohort studies in hip fractures, and then I applied as a suggestion of Bob Winquist, getting back to the mentoring. He suggested that I go and work in the AO research lab in Davos. And I wrote a Swiss National Science Foundation grant on studying the technique called laser Doppler flowmetry that Rick Matson, who wasn't quite then the chairman of the department, he knew that Ernie Weidmuller, who was the head of ENT, had just gotten this tool to measure the capillary level blood flow in soft tissue. And we wondered whether or not it could actually measure bone blood flow. So Rick got a hold of a pig, and we drilled a hole in the pig's femur and stuck that probe in, and miracle of miracles, you could see the blood flow in a bone, which had not been done before. So I wrote a grant to further characterize what that technique was actually measuring, and spent 10, 11 months in the AO research lab doing projects on femoral head blood flow with intracapsular pressure and the effects of compressing a femoral neck fracture versus not compressing on the femoral head blood flow, and a couple other projects. And then when Dan Spangler recruited me to start the level 1 program at Vanderbilt, where I was fortunate enough to meet you as a junior resident, I put in the negotiations that I didn't, want a super high salary. What I wanted was the support of a laboratory tech, so I could keep doing this microcirculation research. And that's what Dan Spangler did for me, and just kept doing it. And then in 1989, switched over to doing clinical trials, and kind of have abandoned the in vivo research and animal models and stuff ever since then.
And then your career then led you back to Seattle. What were the situation? Seemed like you were just getting going at Vanderbilt, and things were really taking off. And then what led you back to University of Washington? Well,
Ted Hansen asked me to come back, and this gets back to the mentor-mentee. He thought that I had the ability to be able to organize things a bit, and that's not Dr. Hansen's skill. He's not really much interested in administration. He's a gifted surgeon and teacher and wonderful physician, but I think he'd rather have somebody put his hand on a granite countertop and hit it with a mallet than go to some meeting and represent the department. So he asked, and it was that 3.5 years at Vanderbilt, that was hard physically. I couldn't have kept that up too much longer. As I recall, it was somewhere between 13 and 17 call nights a month on top of the stuff we were doing. Yeah, it was a different line of work in those days. Most surgeons never lasted much more than 10 years doing that kind of stuff. So I thought, being able to go back to Seattle and working with Steve Venershka, Bruce Sanjorzen, Paul Anderson, Marc, and Swiontkowski, and Mentee, 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 and Swiontkowski, and Who am I? Brad Henley would be.
Keith Mayo.
Yeah, Keith Mayo would be the work would be much better divided. And sure enough, it was. And we were able to organize and kind of get more involved in prospective clinical research and bring in a few wonderful fellows like yourself, and have a research lab that we were able to fund by getting an endowment in honor of Dr. Hansen, so that we had research folks that were doing biomechanics and a wonderful lab to work in. Alan Tenser, as you recall, Alan Tenser, PhD, really ran that lab and was a wonderful facility. So we had the research element that was much better organized, as well as the huge patient volumes for clinical research. And then because of the Vanderbilt connection, John Morris was the chief of general surgery, and he and I were really quite close. And he introduced me to Ellen McKenzie after I'd returned to Seattle. And that resulted in the very first, I think, step of us in the trauma field to doing multi-center trials, when we at Vanderbilt and Shock Trauma and Harborview did the lower extremity outcome study, almost 500 patients with unilateral trauma to the lower extremity, measuring the outcome of those injuries over the first 2 years. Long-winded answer, but it's been a good ride.
One of the things I don't think a lot of people know is that you and Roy Sanders were both working at Vanderbilt at the same time. And I think Roy came as your fellow, but ended up just being your colleague. Could you just comment on how that relationship sort of just spontaneously evolved?
Yeah, that was really interesting. So Dan Spengler hired me, and we negotiated the extra year to go to. Well, I first went to Tanzania for a few months, and that's another story. But then I went to the AO lab, and Dan was willing to wait until I came back. And unbeknownst to me, Dan, who was very close to Viktor Frankl at Hospital for Joint Diseases and soon to be NYU, had a resident named Roy Sanders. And Viktor Frankl asked Dan Spengler to have Roy do a second fellowship. And Dan said yes. And so my very first dinner when I got back to town, when we moved to town, moving all our stuff from Seattle, it had been in storage in John Thayer's basement. We're out to dinner with Dan, and he said, "We got another guest coming." I said, "Who's that?" He says, "Oh, it's your fellow." So there I am, a brand new attending, and Roy is my fellow. Well, the Nashville General Hospital, is, better than I, to be truthful, way better than I, had a real paucity of anybody that really cared about high quality fracture care. And Roy jumped into that void with both feet and did a great job with totally converting the way fracture care was delivered at the institution. And we had a number of times when we'd work together, we'd be on call together, and we did actually the first RCT of Ender's nails versus X-Fix, and so we did collaborate a lot. But he was basically taking care of the Nashville General while I was taking care of Vanderbilt with some cross fertilization, cross coverage.
Yeah, I think it's really interesting how your paths sort of crossed briefly there early in your careers, and then both of you ended up as editors of very the top field journal. Or I just thought that was really interesting. Marc, you've got all these aspects of your character that probably have led to your success. And so, if you break it down, what are the things that are the most important? Is it taking care of the patients? Is it your integrity? Is it your faith? What is it that sort of you would consider, you would tell a young surgeon to really focus on as they're trying to evolve and become you?
Well,
or
that's
their version of success. How about that?
yeah. So as you know, my faith is really important part. I wouldn't be a doctor if I hadn't become a Christian at age 19, which totally changed my life. I was at a point where my best friend had committed suicide, and I was considering following him, that there was no real reason to live. So I wouldn't have gone to medical school if I had, my whole perspective hadn't changed. And as I trained in medicine, I became acutely aware of the fact that we in medicine have a social contract. We have a contract with society that basically says we physicians and nurses are going to act in society's best interest, and in exchange for that, you're going to let us govern ourselves. So we determine who gets in to medicine. We determine how they're educated. We determine how they're certified. We determine whether or not their license gets removed, etc. That's all stuff that we do because of that social contract. And what I would say to anybody that wants to really move the needle on a big problem is you have to put the patient first. That it has to really evolve about what's best for patients. And if you do that, and secondarily pay attention to the difficulties in lives of your colleagues, you can do really big things together, because people will buy into a mission that's altruistic and is based on what's best for the patient. And unfortunately, our field has, in the past couple of decades, more so than ever before, become influenced by people who want to reduce medicine to a simple profit and loss statement. And that is the road to perdition. That's going to lead to politicians getting involved in those essential important events that we control in medicine. So don't go down that road. You're going to have plenty of money to educate your kids and do all the things you want, as long as you're careful with your primary relationships. Focus on the patient, focus on your colleagues, focus on your family, and you'll be able to get big things accomplished.
Marc, in summary, what do you think from the mentors that you've had and the people that you've been a mentor to? What do you think the greatest characteristics or attributes are for the mentors that you've had, and then what do you think is most important to the people that you've been a mentor for?
Yeah, I think it comes down to what I just said, is that the mentors have put the patient first. I can remember Dr. Harvey making rounds on a Sunday, gimping around the hospital because he needed a hip replacement, and said he wouldn't trust anybody that he trained to do it on a Sunday, making sure that what the residents were doing, mostly unsupervised, wasn't a screw up. And Ted Hansen definitely put the patient first. My recollection of Ted is looking through an exam room on 6 South. He's got a patient on an exam table. He's got their foot in his hands, and he's looking up at them, asking them what the problem is. Ted never did anything for money or for fame or anything. It was always about what's best for the patients. And I say that about you. You've never been motivated by anything other than patients or doing some research to make patient care better. So that's what it's all about. Is those are the people to pay attention to, not to the people that are trying to pad their career or be up in the front of the room all the time, or having the last word at conference, or building their ego, which is really their insecurity. Just follow those that really sign on to what the profession of medicine, what the fundamental agreement is, and that's one physician to one patient, with the understanding you're going to do the very best for them that you can to make them better.
Well, you emphasize the clinical aspect of your career, but in the clinical aspect of it, but I also know the one thing that you've, or the several things else that you've instilled in so many of us is just the devotion to research and also the devotion to education. I think those things follow along with the clinical devotion to patient care. We could go on and on and on, and we've exceeded the time that we asked you for, and so I'm going to apologize for running over time. But it's
No, well,
I also tell you we could go on forever.
Yeah, well, it won't be forever, but I have to say this, that if you become an educator, you can influence many more thousands of patients by helping people to think right, to be technically right. And you, Chip, are one of, if not the very best educator of residents and fellows I've ever seen. I know you got a lot of that from Neil Green, another one of your mentors, but you have impacted the care of hundreds of thousands of patients worldwide with your efforts in pelvic and acetabular fracture surgery. And I just need to say that because it's the truth.
Well, I did this because of you, and you told me that actually when I was a PGY4 and I was headed back to Brenham, Texas to hang out a shingle. And so you and Dr. Green, pretty much between you telling me that and him telling me that he wasn't going to sign my certificate if I went into private practice, that pretty much set my train on the rails. So I appreciate that very much, and I really appreciate your time. We're all very grateful for all the things that you've done. I represent everyone in the AO that you've either mentored directly or indirectly, and the impact that you've had on all of us is just well beyond your imagination. I think probably if you sat around and thought about it, you'd figure it out. But I know you don't do things like that. But you've had a huge impact on all of us, and we're really grateful for that.
It's been a privilege, totally a privilege. Okay. I'm as enthusiastic about what I do as the day I started. It's a great life.
That's a wonderful statement. We really thank you for your time, and thank you for all your comments. And I hope to see you soon, and I appreciate what you've done.